We've got some very important orifices in the lower half of the body. Okay, maybe that's not news. But if you know someone with Sjogren's, or if you're watching this because someone in your life just got diagnosed, you probably think of dryness as an eyes and mouth problem. Sandy, gritty eyes. A mouth so dry she can barely swallow a cracker. That's the story everyone gets told. That's the story her rheumatologist tells her. And it's true, but it's incomplete, and that incompleteness is costing a lot of women comfort they don't have to live without. Here's what nobody sits her down and explains. Sjogren's is an autoimmune disease where the immune system targets the exocrine glands, the glands that make moisture, tears, saliva. But the body is lined with moisture-producing tissue everywhere, not just the face. The gut lining secretes fluid to keep things moving. The bladder and the nerves that control it depend on a whole signaling system that autoimmune inflammation can disrupt. And vaginal tissue is mucosal tissue too, dependent on the same kind of moisture production that's failing at the eyes and the mouth. So when women in this community say nobody warned them about constipation, or bloating, or bladder leaks, or vaginal dryness, they aren't imagining a connection. They found one that most doctors don't have time to explain in a 15-minute visit. So today I want to walk through 4 things that get worse for someone with Sjogren's. Digestive and reproductive tract issues that show up more, and show up earlier, in people with this disease than in the general population. I'll cover the classic advice that gets recycled in every generic wellness article. But I also want to hand over something a little fresher for each one, something built around what's actually happening in a Sjogren's body, because generic advice for generic aging doesn't always hold up against an autoimmune disease that's specifically attacking moisture-producing tissue. I want to be clear about something before we start, because it matters. None of these 4 symptoms show up on the standard diagnostic checklist most patients get handed at the rheumatologist's office. That checklist is usually eyes, mouth, joint pain, fatigue, maybe a positive antibody panel. Nobody sits down with a new patient and says, by the way, this disease might also slow your gut down, might mess with your bladder signaling, and might dry out tissue you'd never think to associate with an autoimmune eye and mouth disease. So when these symptoms show up, and they show up for a lot of women, they land as confusing, isolated, embarrassing little mysteries instead of what they actually are, which is more Sjögren syndrome and more autonomic involvement wearing a different disguise. Piecing that together out loud matters, because once you see the pattern, it stops looking like the body randomly falling apart in 4 unrelated directions and starts looking like one disease, reaching further than anyone warned. Problem number 1. Constipation and slow gut motility. If someone with Sjogren's notices her digestion has gotten sluggish, she is not imagining it and she is not alone. This is one of the more under-discussed pieces of the disease. Sjogren's doesn't just dry out the mouth and eyes, it can involve the autonomic nervous system, the part of the nervous system that runs things a person doesn't consciously control, like the rhythmic contractions that move food through the intestines. When that signaling gets disrupted, digestion slows down. On top of that, saliva itself is the first step in digestion. It contains enzymes that start breaking down food and it helps everything move smoothly from the moment it's swallowed. If the mouth is dry, that first step is already compromised before food even reaches the stomach. Think about how much this gets skipped over. A woman goes to a gastroenterologist because she's constipated, and unless she specifically says the word Sjogren's and autonomic, she'll probably get the same generic advice everyone gets: more water, more fiber, more movement. Nobody's connecting the dots to the disease sitting quietly underneath it, because most gastroenterologists aren't trained to think about autonomic neuropathy as a downstream effect of an autoimmune disease they associate with dry eyes. That disconnect between specialties is honestly one of the biggest reasons people with Sjogren's end up feeling dismissed. The rheumatologist manages the disease, the gastroenterologist manages the gut, and unless the patient herself is the one carrying the thread between the 2 appointments, nobody else is going to carry it for her. There's also a texture piece worth naming. A dry mouth changes the way someone chews and swallows, smaller bites, less thorough chewing because it's uncomfortable, sometimes avoiding fibrous foods altogether because they're harder to get down without enough saliva to soften them. So the very foods that would help move things along, the fibrous vegetables, the whole grains, can become foods a person unconsciously eats less of simply because dry mouth makes them harder to manage. That's a quiet, compounding effect that has nothing to do with willpower and everything to do with the mechanics of a drier mouth. The classic advice is water, fiber, and exercise. Nothing wrong with any of that, and if she's not doing those three things, that's the place to start. But if she's already doing them and still stuck, sitting on the toilet feeling like nothing is happening even though she knows she needs to go, that's a sign this isn't a simple lifestyle fix. This is autonomic and mucosal, and it needs an autonomic and mucosal answer. A squatty potty, or really any small stool that elevates the knees above the pelvis when sitting on the toilet, is cheap, it's non-invasive, and for a lot of people it works almost immediately. It straightens the angle of the rectum so there's no need to strain, and straining matters more for Sjogren's patients than most people realize, because straining can worsen pelvic floor issues that already tend to cluster with autoimmune and connective tissue conditions. So this isn't just a comfort upgrade, it's protective. It's a 5-minute fix for a mechanical problem, and it costs about as much as a nice lunch. The second thing worth trying is a psyllium product taken proactively every single day, not just on the days things are already backed up. A lot of women in this community take it in a second cup of coffee, the first cup for pleasure, the second more medicinal, a spoonful of psyllium seed and a small shot of olive oil stirred in. That combination is anecdotal, it hasn't been rigorously studied as a pairing, but plenty of people report it helps, and the mechanism makes sense. Psyllium adds bulk and the olive oil adds a lubricating quality that a dry gut in a dry disease can genuinely use. No need to worry about dependency. Psyllium isn't a stimulant laxative, it's fiber, it's simply replacing what the gut may not be getting naturally, and if the Metamucil brand feels expensive, a plain psyllium husk from Costco or Walmart does the same job for a fraction of the price. One more piece worth adding for Sjogren specifically, hydration timing matters more than most people realize when the baseline moisture is already compromised. Sipping small amounts consistently throughout the day tends to do more for stool consistency than one big glass in the morning, because a dry body absorbs fluid inconsistently when it arrives all at once versus steadily. If she's already carrying a water bottle everywhere for the dry mouth, that same habit is quietly doing double duty for the gut, a nice reminder that a lot of the sicker management already happening is helping in places nobody realized. Here's the sign that should move this from a mild annoyance to a conversation with the rheumatologist. If constipation is new, if it's severe, if bowel movements drop below 3 a week consistently, or if there's unintentional weight loss alongside it, that combination deserves more than a home remedy. Sjogren's related gut dysmotility can sometimes overlap with other complications, and the medical team needs the full picture, not just the surface symptom. Also worth flagging if the constipation alternates unpredictably with episodes of loose stool or urgency. That kind of swing between two extremes is a classic sign of a motility problem rather than a simple fiber deficiency, and it's worth describing exactly that way, as alternating rather than just constipated, because that word alone points a doctor toward a very different diagnostic path. If this is the one that's been quietly frustrating you, the straining, the bloated discomfort, the feeling like your own body isn't cooperating with something this basic, you were never lazy or doing something wrong. Your gut is working against a real signaling problem, not a willpower problem, and that distinction alone is worth holding on to. You are allowed to take up space talking about this with your doctor the same plain way you talk about dry eyes. You are seen, this is real, and you deserve answers that actually fit what your body is doing. If this one was you, drop the word gut in the comments, just so it's said out loud somewhere. Before we continue, hit subscribe and leave a like. That helps this channel reach more people who need it. The goal at Health Inside is 200,000 subscribers, and every single person who joins moves us closer. And if you want the full Sjogren symptom map guide with visuals, symptom breakdowns, and additional resources, type symptom map in the comments, and I'll send you the link to access it. Problem number 2. Bloating and gas that feels disproportionate to what was eaten. I could write a book on this one, and honestly, so could a lot of Sjogren's patients, because this symptom gets dismissed constantly. She eats what feels like a completely reasonable meal and an hour later looks and feels 5 months pregnant. Here's the piece of the puzzle that usually gets left out of every generic gut health article. Sjogren's patients have a meaningfully higher rate of small intestinal bacterial overgrowth, often shortened to SIBO, than the general population. When gut motility slows down because of autonomic involvement, food and bacteria that should be moving along steadily instead sit and linger. Bacteria that are normally kept in check start to overgrow, and they ferment whatever was eaten, producing gas as a byproduct. That's the bloating. That's the discomfort. It's not just what she ate, it's how long it sat there before it moved. This is one of the most frustrating symptoms in the entire Sjogren's picture, because it's so easy for a woman to blame herself for it. She starts keeping a food diary, cuts out dairy, then gluten, then nightshades, then legumes, and the bloating doesn't fully go away because she was never actually chasing the right variable. She was treating it like a food sensitivity problem when it might actually be a transit time problem. Bacteria overgrowing because things are moving too slowly, not because any particular food is inherently the enemy. That's an important distinction because it changes what she's even looking for. A food sensitivity test hunts for the wrong culprit. A motility and overgrowth conversation hunts for the right one. There's also a connective piece here worth naming plainly. Autonomic dysfunction in Sjogrens doesn't only slow the large intestine, it can affect the small intestine too, and the small intestine is where SIBO actually lives and does its damage. So a slow gut isn't just an inconvenience that shows up as constipation on one end, it's also quietly setting up the conditions for bacterial overgrowth further upstream, which is why the same underlying mechanism can produce two symptoms that feel completely unrelated on the surface: sluggish bowel movements and disproportionate bloating, when really they're two expressions of the exact same slowdown. The standard advice is to avoid gassy foods, cut out beans, cut out cruciferous vegetables like broccoli and cauliflower and Brussels sprouts. But those are some of the healthiest foods a person can eat, and if the real driver is bacterial overgrowth from slow motility rather than the vegetables themselves, cutting them out treats the wrong problem. She ends up with a smaller diet and the same underlying issue. The fresher approach starts with recognizing this might not be a food problem at all, it might be a motility problem, and that reframes what to ask a doctor for. A simple breath test can screen for SIBO. If it comes back positive, that's treatable, and treating the actual overgrowth does more for the bloating than another year of eliminating vegetables ever will. In the meantime, movement genuinely helps. A short walk after eating stimulates gut motility and helps move gas along instead of letting it sit and build pressure. It's not a cure, but it's a real physiological nudge in the right direction while the bigger picture gets sorted with the medical team. Worth gently pushing back on the instinct to keep shrinking the diet every time bloating flares. It's an understandable instinct, cut the thing that seemed to trigger it, but if the actual driver is overgrowth rather than the food itself, a person can end up eliminating category after category and still feel just as bloated, just with a much smaller and less nourishing diet to show for it. That's a hard cycle to be in, and it's not a personal failure, it's a sign the root cause was never actually addressed. Bringing SIBO into the conversation with the doctor by name tends to redirect the whole workup towards something that can actually be treated instead of endlessly narrowed around. The sign to watch for here: if the bloating is severe, if it's paired with significant unintentional weight loss, or if new food intolerances are appearing seemingly overnight, foods that used to sit fine suddenly causing problems, that pattern is worth bringing to the rheumatologist directly, asking about gut motility and SIBO by name. Those two words tend to get a much more productive conversation started than just describing bloating in general terms. Also worth tracking the timing pattern: bloating that builds steadily worse as the day goes on and is at its mildest first thing in the morning is a particularly recognizable signature of bacterial overgrowth, because bacteria have had all night to settle and multiply less, then the fermentation builds again over the course of the day. That specific morning to evening pattern is a detail a lot of people don't think to volunteer, and it can be genuinely useful diagnostic information. If you've spent months blaming yourself for what you eat, quietly narrowing your own diet meal by meal trying to chase down a culprit that was never really there, please hear this: that exhaustion makes complete sense and it was never a personal failing. Your body has been dealing with something mechanical, not moral, and you don't owe anyone an apology for how your stomach looks after dinner. You're allowed to stop shrinking your life around this. You are seen, this pattern is real, and there is a steadier way through it than you've been given credit for finding on your own. If this one was you, drop the word bloat in the comments, just so it's said out loud somewhere. Problem number 3. Bladder issues, urgency, and leaks. This is one that catches a lot of Sjogren's patients off guard because it doesn't sound like it belongs on the same list as dry eyes. But this disease can involve the autonomic nervous system, and the bladder runs on autonomic signaling, the nerves that signal when it's full, when to hold, when to release. When that signaling is inflamed or disrupted, urgency can show up that seems to come out of nowhere, needing to go constantly, or leaking with a sneeze, a cough, a laugh, or standing up quickly. On top of the nerve piece, some Sjogren's patients also develop a kind of bladder inflammation called interstitial cystitis, which mimics a urinary tract infection but doesn't show up as one on a standard test. Anyone who's gone to urgent care with what felt like a UTI and been sent home with a negative culture and no real answer, that pattern is worth mentioning to the rheumatologist specifically, because it doesn't always occur to a general practitioner to connect the two. This is one of those symptoms where the frustration compounds on itself. The burning, the urgency, the sense that something is wrong down there. She gets tested, the culture comes back clean, and now there's a symptom and no explanation, which somehow feels worse than an explanation nobody likes. A lot of women in this exact spot get quietly told it's probably stress, or probably just part of getting older, and they walk away with a real physical symptom rebranded as something vague and psychological. It isn't vague. Interstitial cystitis is a recognized, diagnosable, treatable condition, and it shows up in autoimmune populations, including Sjogren's, at higher rates than in the general population. The key is knowing the name of what to look for before walking into that appointment, because that single word tends to redirect the whole conversation. The classic advice is Kegels, tightening and releasing the pelvic floor repeatedly as a preventative exercise. Show me a woman who reliably remembers to do these every single day. Most people who try triggering themselves to do it at red lights still forget half the time. That's not a failure of self-care, that's just being human. The fresher, more realistic approach is called the clench, and it's exactly what it sounds like. Instead of relying on a routine that's easy to forget, the moment itself becomes the reminder. Feel a sneeze coming on, about to laugh at something, bending down to pick something up, tighten the pelvic floor hard right before that moment. Some research on stress incontinence suggests this kind of just-in-time clench is roughly as effective as consistent preventative Kegels, and it has one major advantage: it actually gets remembered, because the body is already giving the cue. What makes the clench particularly useful for a Sjogren's brain, and brain fog is its own well-known part of this disease, is that it doesn't ask anyone to build and maintain a habit that lives entirely in memory. Kegels require remembering a routine on a day when remembering anything can already feel like wading through fog. The clench piggybacks on a cue the body is already generating. The sneeze itself is the reminder, the laugh itself is the reminder, so it works with a foggy brain instead of demanding a sharp one. The sign that should prompt a real conversation with the doctor: if the urgency or leaking is new, if it's severe enough to affect how the day gets planned, or if UTI-like symptoms keep showing up and testing negative for infection, that shouldn't get quietly absorbed into just another Sjogren's symptom to live with. Interstitial cystitis and autonomic bladder dysfunction are both manageable once actually identified, but they can't be treated if nobody names them. A rough log for a couple of weeks helps. How often, whether it burns, whether it's tied to specific foods or drinks like coffee or acidic juices, because interstitial cystitis often has identifiable triggers that a straightforward infection doesn't. And walking into an appointment with that pattern already mapped out saves an entire round of trial and error the doctor would otherwise have to walk through from scratch. If you've quietly rearranged your whole life around where the nearest bathroom is, or you've been told that burning feeling is just stress one too many times, none of that dismissal makes what you're feeling any less real. Your nervous system is genuinely involved here, and needing to plan your day around your bladder isn't something to be embarrassed about. It's information your body has been trying to hand you all along. You don't have to keep shrinking yourself to manage this quietly. You are seen. This is a real and nameable part of your disease, and steadier days than this are possible. If this one was you, drop the word bladder in the comments, just so it's said out loud somewhere. Problem number 4. Vaginal dryness. Anyone who checks their spam folder regularly already knows the internet is obsessed with erectile dysfunction. It's probably 90% of what lands in there. And a lot of men write in asking why their wives have lost interest in sex, which is its own ironic mismatch, because so much attention goes to one side of that equation and almost none to the other. One of the real, physiological reasons a woman might lose interest isn't emotional distance, it's vaginal dryness, and for someone with Sjogren's, this isn't incidental, it's often central. Sika syndrome, the dryness that defines this disease, doesn't selectively spare mucosal tissue below the waist. If the eyes and mouth are dry because the exocrine glands are under autoimmune attack, the same category of tissue lines the vagina, and it can dry out through that same mechanism, completely independent of menopause or hormone levels. This is probably the symptom that gets the least airtime of all 4, and shame is a big part of why. Women will talk about dry eyes at a support group meeting without blinking, pun somewhat intended, but vaginal dryness stays quiet, private, unmentioned, even in spaces specifically built for people with this disease to compare notes. And because it stays quiet, the assumption that it's just a menopause thing goes completely unchallenged. Younger women with Sjogren's, well before menopause, experience this symptom too, and when it happens to them, it's even more disorienting, because none of the standard explanations apply. It isn't age. It isn't hormones declining on schedule. It's sicca, showing up exactly where sicca shows up, in moisture-producing mucosal tissue, which happens to be everywhere in the body, not just above the collarbone. That distinction matters a lot, because the classic advice, hormone replacement therapy, is built around the assumption that vaginal dryness is a menopause problem. HRT can genuinely help some Sjogren's patients, and for anyone having significant postmenopausal symptoms on top of Sjogren's, it's worth discussing with a doctor. But if the dryness is being driven primarily by autoimmune sicca rather than estrogen decline, hormone therapy alone may not fully address it, because the missing piece isn't just estrogen, it's the moisture-producing capacity of the tissue itself. For anyone who doesn't want to go the hormonal route at all, the fallback advice is usually just lubricants, and lubricants have a real limit. They only help in the moment, during sex, for a short window of time. The fresher approach is to separate lubricants from vaginal moisturizers, because they are not the same category of product even though they get lumped together constantly. A lubricant gets applied right before sex and works for that limited window. A vaginal moisturizer is used 2 or 3 times a week regardless of sexual activity, and with consistent use it gradually thickens and rehydrates the tissue itself, which means it helps with discomfort during intercourse but also with everyday discomfort, sitting, walking, just existing in the body, that a lubricant simply cannot touch because it isn't designed to be a maintenance product. For Sjogren's patients specifically, treating vaginal dryness as an ongoing sicca symptom that needs consistent maintenance, the same way eye drops get used multiple times a day rather than only when the eyes feel unbearably dry, tends to produce a lot more relief than treating it as an occasional inconvenience to patch right before sex. That reframe is honestly the whole point of this segment. Nobody waits until their eyes feel unbearable to use eye drops. They get used proactively because the dryness is known to be chronic and ongoing, not situational. Vaginal sicca deserves that same proactive maintenance mindset instead of the reactive, only when it's a problem approach that lubricants encourage by design. Once it gets treated as a maintenance symptom rather than an occasional inconvenience, the whole daily experience of it tends to shift, not just the moments right before intimacy. If an over-the-counter moisturizer isn't cutting it, that's worth raising with a doctor, because there are low-dose vaginal estrogen creams that work locally on the tissue with very minimal systemic absorption, meaning far less of it ends up in the bloodstream compared to conventional hormone replacement therapy. That can be a meaningful middle ground for anyone who wants relief without committing to full systemic HRT. And for anyone who's already tried HRT and it didn't fully resolve the dryness, that's not a sign it failed, it's a sign the dryness may be coming more from the sicca mechanism than from estrogen alone, which is exactly the kind of detail worth relaying back to whichever doctor prescribed it, because it can shift the plan toward a local, tissue-level approach layered on top of what's already being done rather than simply increasing a dose that was never targeting the actual source. If this is the part you've never said out loud to anyone, not a partner, not a friend, not even your own doctor, that silence makes sense, but it was never something you needed to carry alone or feel ashamed of. This is your body doing exactly what a dry disease does to moisture-producing tissue, nothing more complicated or shameful than that. You are allowed to name it plainly and ask for help with it the same way you'd ask about dry eyes. You are seen here, this is real, and there is real, quiet relief available once it finally has a name. If this one was you, drop the word dry in the comments, just so it's said out loud somewhere. So here's where all 4 of these come back together. Constipation, bloating, bladder urgency, vaginal dryness. On the surface these sound like 4 unrelated inconveniences, the kind of things people quietly stop mentioning to their doctor because they feel embarrassing or unrelated to the real disease. But they are not unrelated at all. They trace back to the same 2 things driving Sjogren's everywhere else in the body: glandular dryness in mucosal tissue, and autonomic nervous system involvement disrupting signals the body relies on to function smoothly. Once that thread is visible, these stop feeling like 4 separate mysteries and start feeling like one coherent picture. The same disease showing up in places nobody warned anyone to look. This framing matters because it changes how someone walks into her next appointment. Describing 4 seemingly unrelated symptoms one at a time, in isolation, bloating, urgency, dryness, constipation, tends to read as 4 separate minor complaints and often gets 4 separate, somewhat dismissive responses. But describing them as one pattern, telling the doctor these all seem connected to the same ccp and autonomic mechanism driving the rest of the Sjogrens, shifts the conversation. That's no longer a patient with a list of vague complaints, that's a patient who has correctly identified a coherent physiological pattern, and doctors tend to respond very differently to that framing, because it shows the hardest part of the diagnostic work has already been done. It's also worth remembering that not every doctor is going to make that connection on his or her own, even when it's brought up clearly. Rheumatology, gastroenterology, urology, and gynecology are 4 different specialties, and Sjogren's is exactly the kind of disease that falls into the gaps between them, because no single specialist owns the whole picture. That's not a failure on the patient's part or even necessarily a failure on the doctor's, it's a structural gap in how medicine is organized around single organ systems for a disease that doesn't respect those boundaries. Which means, frustratingly, the patient often ends up being the one holding the full picture together, carrying the thread from one appointment to the next, because nobody else is positioned to do it for her. That's an unfair amount of responsibility to carry on top of an already exhausting disease, but knowing the mechanism, knowing the specific words to say out loud, ccp, autonomic, motility, overgrowth, tends to make that job noticeably lighter. If any of this sounds familiar to someone watching, if she's been quietly dealing with one or more of these and wondering whether it even counts as a real symptom worth mentioning, she should know she is not imagining it, and she is not alone in noticing it. So many women with this disease feel unheard on exactly these 4 issues because they don't fit the textbook description of dry eyes and dry mouth. She is seen, this pattern is real, and it has a name and a mechanism behind it, which means it also has real, practical things that can help. It's also worth saying something to anyone who has felt embarrassed bringing these particular symptoms up, to a partner, to a friend, to a doctor. There is nothing embarrassing about a body responding to an autoimmune disease exactly the way that disease is known to behave. Bloating isn't a character flaw. A bladder that leaks with a laugh isn't something to apologize for. Vaginal dryness isn't a sign that something is wrong with a person, it's a sign that a specific type of tissue is under the exact same kind of attack the eyes and the mouth are under, and that tissue happens to be somewhere women were taught not to talk about it. It's worth talking about anyway, bringing it to appointments with the same matter-of-fact tone used for describing dry eyes, because it deserves exactly that same level of ordinary, unashamed attention. These aren't glamorous topics. Nobody wants to sit around talking about bowel movements and bladder leaks and vaginal dryness. But they are facts of life with this disease, and they don't mean someone is falling apart, and they definitely don't mean she's the only one dealing with them quietly. They mean the immune system is doing what it does in this condition, an understanding that gives something a lot more useful than silence, it gives a place to actually start. And for anyone realizing they've been carrying one or more of these symptoms alone, quietly, for longer than they'd like to admit, hopefully this at least gave the words to describe it out loud, because being understood is very often the first real step toward being helped. One last thought before closing. If nothing else lands from this, let it be the shift in framing. Stop treating each of these 4 symptoms as its own isolated inconvenience to quietly manage or quietly hide, and start treating them as part of the same disease process already understood through the eyes and the mouth. Anyone living with this already knows how to describe ccp, already knows how to describe fatigue and joint pain and brain fog to the people in their life. These 4 symptoms deserve that exact same plain, unashamed vocabulary, because they come from the exact same place. Nobody is falling apart in 4 separate directions, this is one disease that happens to reach further than anyone warned it would, and naming that clearly is how the care starts matching what's actually happening in the body.